Progression is usually defined in multiple myeloma either as the biochemical progression, which is an increase in the monoclonal protein present in the blood. On clinical trials, we require an increase of at least 0.5 grams per deciliter of the monoclonal protein, or an increase in the serum free light chain of at least 10. We generally require that is repeated at least once to confirm that the relapse is real and not just lab variation. Relapse can also occur outside of the bone marrow with extramedullary disease, which is a plasmacytoma growing outside of the bone marrow itself. And we can sometimes see that in the absence of increase of the biochemistry. But usually one or both of those things will be present at the time of relapse. In an elderly patient like the one that we are discussing, a biochemical relapse alone would probably not be adequate reason to change or at least to start new therapy, assuming they were not currently on treatment. We could often follow a patient like this as long as they're asymptomatic and where quality of life is important. However, if the monoclonal protein is rising rapidly, or there are any signs of impending end organ damage, either by imaging, symptoms, or physical exam, then I think in a patient like this, treatment would be indicated. In this patient, he is presented with increasing pain and fatigue, clearly beginning to show signs of problems, and a switch in therapy is absolutely required. In a patient who has asymptomatic biochemical relapse, in an elderly patient, one might just give a break of therapy and watch for a while to make sure that to see how long the disease will remain stable. If the physician feels therapy is recommended, one would generally look for drugs with the lowest toxicity profile to employ before going to more aggressive and more toxic therapies. Phase 3 clinical trials of the use of immune modulator drugs such as lenalidomide have demonstrated the following. When compared to the control in a trial that was called the FIRST trial, probably one of the largest trials ever performed in multiple myeloma with over 1,500 patients. The control arm, which was melphalan, prednisone, and thalidomide, did about the same as those patients treated with lenalidomide, dexamethasone for 18 months, who then had their treatment discontinued. The arm of the trial that was clearly superior in terms of progression-free survival was the use of lenalidomide and dexamethasone continuously. This, along with maintenance studies of lenalidomide in the post-transplant setting, confirmed that patients should really stay on these drugs somewhat indefinitely, as long as they're tolerated and there's no concern for secondary side effects. In this patient, the dose of lenalidomide was escalated from 15 to 25 milligrams, or full dose. I think this was appropriate to try. The patient was not suffering serious toxicities at the lower dose, was showing asymptomatic biochemical progression initially, and thus an escalation of dose to see if that was also tolerated and whether that might recapture control of disease, I think was an appropriate attempt at managing this patient given his circumstances.